When you have a pregnant or laboring patient in the back of your ambulance, what do you really need to know? What questions help you predict the complications you may face in the next 20 minutes? In pre-hospital obstetric care, the patient's history is not just background information. It directly shapes your assessment, transport decisions, level of concern, and preparation for possible emergencies before arrival at the hospital. A focused obstetric history can quickly reveal whether this is likely to be routine labor or a high-risk situation. Let's break it down into categories. Category 1. Conception. We do not need intimate details about conception. We only need to know whether this pregnancy was conceived naturally or through IVF, in vitro fertilization. IVF pregnancies are medically higher risk than average pregnancies. These patients have increased rates of placenta, previa, preeclampsia, multiple gestation, preterm birth, and other complications requiring close monitoring throughout pregnancy. If your patient tells you this is an IVF pregnancy, your level of awareness should immediately increase because these pregnancies are often medically fragile. There is also an emotional component during patient care. Many IVF patients have spent years struggling with infertility, recurrent pregnancy loss, failed procedures, emotional stress, and significant financial burden before achieving this pregnancy. Because of that, they are often extremely attentive to every symptom, every cramp, every episode of bleeding, and every perceived change in fetal movement. That means your communication matters. These patients may already be terrified that something is wrong before you even arrive. A calm, confident assessment can reduce anxiety while helping you gather the information you need. Category 2. Complications in prior pregnancies. Many obstetric complications repeat themselves across pregnancies. A prior complication often predicts future complications, which is why a detailed pregnancy history is so important in EMS. You need to ask about ectopic pregnancy, chronic hypertension, gestational diabetes, preterm labor, and hyperemesis gravidarum. An ectopic pregnancy is a pregnancy implanted outside the uterus, most commonly inside the fallopian tube. Patients with a prior ectopic pregnancy may be considered higher risk in future pregnancies and may be followed more closely by obstetric specialists. Hypertension during pregnancy is another major concern. Chronic hypertension and gestational hypertension both increase the risk of preeclampsia, placental complications, stroke, seizures, and maternal instability. If a patient previously developed severe hypertension during pregnancy, you should pay close attention to symptoms such as headache, visual changes, swelling, abdominal pain, or elevated blood pressure. Gestational diabetes is also clinically important. Patients with prior gestational diabetes are at higher risk of developing it again and may experience more difficult deliveries and neonatal complications. Preterm labor history is one of the most important details you can obtain. A patient who previously delivered at 32 weeks or 34 weeks is at significantly higher risk of doing it again. If she is currently contracting early in pregnancy, that history should immediately increase your concern and may change transport priorities. Hyperemesis gravidarum deserves special attention. This is not normal morning sickness. This is severe, chronic, debilitating nausea and vomiting that can continue throughout the pregnancy and often does not respond to standard anti-nausea medications such as ondansetron. These patients become dehydrated, malnourished, and may lose dangerous amounts of weight. Repeated vomiting can cause electrolyte abnormalities, weakness, dizziness, and in severe cases, upper gastrointestinal bleeding from constant retching. If this patient lives in your response area, you may transport her repeatedly during the pregnancy. EMS providers should recognize that traditional anti-nausea medications may provide little relief for these patients. They often require IV fluids, electrolyte correction, monitoring, and hospital admission. When documenting, clearly note the history of hyperemesis gravidarum because it immediately explains why the patient appears exhausted, dehydrated, or unable to tolerate oral intake. Category 3. Complications in the current pregnancy. Historical complications matter, but active complications matter even more. Ask the patient whether she is currently being monitored for anything during this pregnancy. Is she being followed for placenta previa, preeclampsia, cervical insufficiency or short cervix, fetal growth restriction, gestational hypertension, diabetes? This is active risk, not historical risk. Placenta previa means the placenta is covering or partially covering the cervix, creating significant risk for bleeding. Preeclampsia introduces the possibility of severe hypertension, seizures, stroke, organ damage, and maternal or fetal instability. A short cervix increases the likelihood of premature labor. Fetal growth restriction may indicate placental insufficiency or chronic fetal compromise. A patient already under specialist monitoring is telling you this pregnancy is not considered low risk. Category 4. Prior deliveries. Ask about previous deliveries in detail. How many weeks pregnant was she during prior deliveries? Were they term or preterm deliveries? Was the delivery in the hospital or outside the hospital? If an out-of-hospital delivery occurred, determine whether it was planned or unplanned. There is a major difference between a planned home birth and a patient who unintentionally delivered before reaching the hospital. That distinction affects both your preparation and the patient's psychological state. A patient with a history of rapid labor may deliver again very quickly. If she previously delivered before EMS arrival, prepare for another imminent delivery. You also need to ask whether prior births were vaginal deliveries or cesarean sections. If she previously required a C-section, determine whether it was planned or emergent. If it was emergent, ask why. Was it because of cord prolapse, fetal distress, failure to progress, placental complications, severe maternal hypertension? Previous delivery complications often predict future complications. Category 5. Medicated versus unmedicated deliveries. This is an area EMS providers often overlook, but it matters significantly. If all of a patient's previous deliveries were epidural-assisted and she is now delivering unmedicated in a home, vehicle, or ambulance, this may be the first time she has fully experienced the pain and sensations of advanced labor. She may not understand how intense contractions become during late-stage labor. She may not know how to coordinate pushing effectively without coaching. She may become overwhelmed, panicked, exhausted, or unable to control her breathing. Patients who intentionally plan unmedicated deliveries often spend months preparing mentally and physically for labor pain and coping techniques. A patient who expected epidural pain control but suddenly does not have access to it is in a completely different psychological and physiological situation. That difference matters during patient interaction. These patients may require more reassurance, coaching, and clearer communication from EMS crews. Document this history because it helps explain the patient's current distress level and labor behavior. Category 6. Complications during prior deliveries. Ask specifically about complications during labor and delivery. Was there a breech delivery, shoulder dystocia, assisted delivery using forceps or vacuum extraction? And by vacuum extraction, we mean a medical suction device attached to the fetal head, not a household vacuum cleaner. You also need to ask about cord complications. Was there a cord prolapse, a nuchal cord wrapped around the baby's neck, a short umbilical cord creating delivery complications? These details matter because previous obstetric complications can increase future delivery risks. Finally, ask about postpartum hemorrhage. A patient who previously experienced postpartum hemorrhage is at increased risk of hemorrhaging again. If she bled heavily after prior deliveries, your preparation changes immediately. You should already anticipate rapid bleeding assessment, monitoring, uterine massage if indicated, fluid management, and rapid transport. Your preparation for today often starts with understanding what happened yesterday. In EMS, obstetric emergencies develop quickly and often with very little warning. A focused pregnancy history allows you to recognize risk factors early, anticipate complications before they occur, communicate more effectively with receiving facilities, and mentally prepare for what may happen before arrival at the hospital. The questions you ask in the back of the ambulance are not routine paperwork. They are clinical tools that help you predict danger, guide assessment, improve patient care, and prepare the hospital for the next critical minutes of treatment.